Hi, it's Dr. Centeno, and thanks so much for joining us. I am trying some new software today, trying to see if we can, or if I can fully understand the whole Facebook Live environment here. But as usual, I'll start with my topic, and then you're free to ask any question you have at any time. And again, that question doesn't have to be on topic. That question can be just about anything you want to learn about. Uh, so my topic today is during the PICL procedure, or when patients come in for that procedure to treat their craniocervical instability, or CCI, we will see patients who really want other areas treated. So let's say an SI joint, their low back pain, their upper back pain, their shoulder, their hip, etc. And for the most part, we're happy to do that, especially if we have the cells to do it. But sometimes we're a little bit cautious before we understand how the patient's going to respond to this kind of therapy or treatment. So, it can be done. We're happy to do it. Obviously, sometimes it requires more time to be booked, so we should know ahead of time. And then sometimes we're a little bit cautious because we don't know how the patient's going to respond to procedures, and we don't want to give them a massive flare-up. So we'll probably ask that patient questions about how they have flared up with prior procedures, whether or not that flare-up was significant, how long it lasted, et cetera, et cetera. And if the patient doesn't seem like they're the kind of patient that's going to have a big flare-up, we will then decide, hey, we're good to treat a couple different spots. So that's how we handle that particular issue. So let me open it now up to questions. And I'm on this new software, so I'm going to see how that goes. So we'll start here. Submitted advanced by Era Hype. I've severely sprained my C1. The movement I made was by looking to the left, and from, I think, that position, bending my head sideways severely. I kept being dizzy. My C1 and C2 are now loose. I have no idea what to do. What scans could be best? Could PRP help with this? Era, I think the big thing is if this is a chronic problem, meaning more than just an acute sprain, then you're going to want to get some initial imaging. Obviously, the first thing is something like a routine cervical MRI. That's not going to really tell us too much about the upper cervical spine, but it may help to rule out other things. And then after that, a digital motion X-ray would be a good idea. But again, you're going to want this, if it's acute, meaning it just happened, to have 3 or 4 weeks to work itself out before you get into the situation of doing this kind of imaging. You might also consider going to an upper cervical specific chiropractor. Those types of chiropractors include NUCA and AO, as well as Blair. So that's another thing you might think about. Rob Long, question, do rotation CT scans revealing things specific past traditional flexion extension neutral studies? Yeah, Rob, that's a really great question because what we're seeing, or what we have seen with that, is the good news is there is some research on rotational CT and craniocervical instability. That was studied by a gentleman by the name of Dvorak, and he did define what was normal and abnormal. The problem is that it's a lot of X-ray exposure, and it's only really looking at rotational instability of C1 and C2. So it won't tell us if there's AP instability. It won't tell us if there's overhang instability, those sorts of things. So it's helpful. It's always good to have more information, but if I look at the amount of X-ray exposure versus what I'm getting out of it and the likelihood of diagnosing CCI on that particular study, probably better to either do a movement-based MRI or DMX. Stevie Ann Williams, how do you determine if someone could benefit from posterior PRP Can C1, C2 instability also be caused by posterior ligaments only? Yes, Devian, when it comes to posterior PRP, we're really looking at two things. The first would be we're not 100% clear that this person has an upper cervical issue, in which case we want to treat the upper cervical facets and or spine and the posterior ligaments, which is a less risky approach. And only less risky because we've got more information on the overall complication rate through hundreds of thousands of those types of injections. Or the patient wants to take a half step. So if there's clear C1, C2 instability, those are the two things we look at for choosing that posterior approach. Now, when patients start at the posterior approach and have clear CCI, or in this case, AAI at C1, C2, then it's about 1 in 5 who don't go further. So realize about 4 in 5 will still need a PICL. So it's certainly possible to help someone that way. And I would always tell patients, if you have any sense of trepidation with doing a PICL, let's take the half step and treat it posteriorly and see if you're one of those 1 in 5 patients. Centeno-Schultz Clinic submitted advance by Harry Winston. Since I'll be traveling from England, is there a way to determine in my online evaluation of PICL whether I would be able to get my low back treated as well? Yeah, Harry, the big issue there is going to be how well you tolerate these types of procedures and injection-based spine procedures. So the questions we're going to ask might be something like, have you had your back or your neck injected before? Yes. How long was that flare-up and how bad was that flare-up? I was sore for 3 or 4, maybe 5 days. After that, I was kind of back to where I was before. In which case, for that kind of patient, we would treat your back at the same time in all likelihood. Now, compare that to the other end of that spectrum. Have you had your neck or back injected before? Yes, it was awful. I was really, really bad, unable to get out of bed for 2 months as a result of that injection. Then the answer is going to be no. You're in that centrally sensitized group, so we don't want to do that. Rob Long, I met a patient with HEDS deemed surgical via BAI translation. I want to encourage eugenics and a good advice for such a person. Yeah, we certainly see patients with movement in their BAI, which is going to be a measurement, so everyone understands, between the skull and the dens, or Bayesian interval. And that's certainly a type of patient that we can treat. As far as trying to keep them away from surgery, I think, it's the same old thing that I've talked about, right? And that is, at the end of the day, if this kind of thing fails, it's minimal risk compared to surgery, and you can still do surgery. If surgery fails, you can't go backwards. There's no way to turn that ship around. Era, about my situation, I've had an upright CT flexion extension before this happened. After having side bended my head forcefully, rotation feels like the C1. So then, Era, if you've already had that done, I think a DMX would be a good next step to look for C1, C2 overhang. But again, I'd have to review your case, but that's just in general in talking to patients who have that kind of situation. Hi, I have damage to my axial membrane and PLL. Do I need stem cells for this? I think I have symptoms of syrinx. Is this procedure not safe for those with syringomyelia? Thank you. So axial membrane, I think you might be talking about the atlanto-occipital membrane, or AAOM. So we would have to come from the front to treat that. PLL would have to be treated through the disc. So Becky, the best thing there would be taking a look at all of your imaging and trying to see what's going on. I think what you're doing is kind of taking stuff off a DMX report or other report, and we've got to really see what's happening, what's causing that at a higher level than just sort of reading the report. So I'd have to really look at that and see if you really need those areas injected. But the AAOM can only be injected from the front. The PLL also only from the front. The PLL is even higher risk than the AAOM. And as far as stem cells for that, if we were doing the PICL procedure from the front, it would be bone marrow concentrate, which has stem cells. As far as having a syrinx, that may or may not mean anything in the big picture. I'd have to know more. Stevie Ann Williams, can one get instability can one get instability by just years of having a bad posture? You know, Stevie, that's a really, really interesting question. I think it's possible in that it would be years and years of bad posture, or perhaps even a scoliosis, plus a lot of wear and tear and age. So for instance, for example, let's think about this for a second. If I do this all day and I'm doing this all day, I'm putting myself in a position where I'm hanging on those upper cervical ligaments. So I'm hanging on the transverse ligament, I'm hanging on the alar ligaments on both sides. So in that situation, with enough time, age, meaning decreasing my native repair, and wear and tear, I can get degeneratively unstable. So yes, I think that can happen. Janelle, how much C1C to overhang is considered too much, more than 5 millimeters? Yeah, Janelle, that's a great question, and I think an important one for everyone to understand. So when it comes to C1C2 overhang, there was a study by Katz et al. Done about 2 years ago now that looked at C1C2 overhang and the number of millimeters. And if it was 3 millimeters or greater, there was a 95% chance for traumatic CCI. If it was 2 millimeters to 3 millimeters, then there was a 2/3 chance of traumatic CCI. So we use the 3 millimeters as a cutoff, as having a high confidence interval that we're looking at CCI on the imaging. Now, realize that that has to be combined with other things, right? The patient has to have a reason to have CCI. The patient has to have symptoms consistent with CCI, have an exam or other treatment that's consistent with CCI. All of that good stuff has to line up. Sharon, can a reverse curve on itself cause symptoms? Yeah, Sharon, it can. There's some really nice work done by the Harrisons. Those are the chiropractors that started chiropractic biophysics. And the father and the son, I think the son is Deed, have done some excellent research showing that just a reverse curve by itself can cause symptoms. And also that fixing the curve through a curve restoration can reduce symptoms. So some really nice research has been done on that. Marcus, your blog on facet joint pain was very helpful. Can you explain why someone only feels the throbbing pain when laying down, resting, or using infrared heat? Throbbing pain only with laying down. A lot of that is often arthritic pain. So you may remember your grandparents, right? Your grandparents, if you really watched them and understood, let's say their arthritic knees or their ankles, what they would find is that in the morning, it tends to be worse. As they get moving, it's less. And when they just start to lay down, it can be more because those joints tend to swell. So usually that's some sort of arthritic pain, obviously in this case, facet joint arthritic pain in all likelihood. Pia, are you working with any clinics on PRP treatments in Europe for lower cervical, spine, jaw, etc.? Can you recommend one? Yeah, Pia, we've got a great clinic in London on the regenerative.com website. I think the regenerative.com web address is scrolling across right there. If you go and find a provider, the Algocells Clinic in London can help you with all of the other non-high upper cervical stuff. Daniel, hi. Which series on a UMRI show? Oh, upper cervical MRI, or maybe upper right MRI show the C2. Is it axial TW? Yeah, so So let's talk a little bit, Daniel, about that, because I think this is an important thing for patients to understand. So on a cervical MRI, we have the different series. Now, all a series means is that it's a different weighting for the image. So for instance, there's a weighting that causes fluid to show as bright. That's a T2 or a fat sat weighting. There's a weighting that causes fat to show as bright. That's a T1 weighting. So those are different weighting of the same image. And then there's the imaging planes, right? You've got sagittal coming in this way, axial this way, coronal that way. And then there's slices going forward, backwards. You can change the slice thickness, all of that good stuff. Meaning you can have thicker slices, thinner slices. Obviously, thinner slices show more things. So at the end of the day, the weighting, pretty much all weighting is, or all series are going to go show C2. Now, if we're looking at the ligaments, the best weighting would be a proton density fat sat, or PDFS. So if that's available and you want to look at the upper cervical ligaments like alar and transverse, that would be the way to go. An axial T2 weighted image, which is the sequence you're talking about there, really would show water as bright. It might be a reasonable one to look at the ligaments as well, because it might show swelling in the ligaments, because it's going to show water as bright. And it might show other things like swelling in the facet joints or swelling around the bursa that's close to the transverse ligament. Can instability just be muscular, not caused by lax ligaments? You know, Sharon, it's a very good question. I think it brings up a very good point for everyone to understand. We have instability, which is ligament plus muscles. So in order to be stable, you've got to have good ligaments and good muscles. Now, is it possible to be unstable when just the muscles are bad? And the answer is yes, that happens. We see it a lot in the low back, where we'll get atrophy of the stabilizing multifidus muscle, and that atrophy then causes instability because those muscles can't keep the vertebra stable as the patient moves. Now, do that for long enough, and eventually you're going to get degenerative instability to beat up ligaments. But the answer is yes, instability can be just muscular without lax ligaments. Now, if you're talking about CCI directly, that's a harder one, because if you're beyond those norms, you generally have to have ligament damage to get beyond those norms that we all talk about. But it can exist that way. We've certainly seen patients with upper cervical atrophy who are unstable just because they don't have the musculature needed there. But they're probably not going to show as unstable, for instance, on a DMX, because the ligaments are supposed to be that court of last resort. The muscles go away, the ligaments are the last thing to keep it stable. So you wouldn't expect to see abnormal motion on movement-based imaging if that were the case. Stevie M. Williams, can instability due to muscle imbalance and not just caused by lax ligaments? Yeah, kind of similar thing with Sharon, really same issue. You can get, I wouldn't call it, let's call it dynamic instability, meaning that you've got muscles that stabilize one vertebra on the other. And as you move, they keep those vertebrae completely aligned. Now, if those muscles are imbalanced or atrophied, then things start to move in strange directions. But regrettably, we don't normally pick that up on movement-based imaging. So when we're looking at something is moving too much, like a C1, C2 overhang, or if we're looking at something like a DENS, which is too far back, meaning an abnormal Grab-Oaks measurement, that assumes that the ligaments also have to be damaged. Submitted advance by Carolyn Schmickus. Is there something that we can do to boost our stem cell numbers so that it's more likely to be able to treat an additional issue? Yeah, the big thing there, Carolyn, I would say it's the big three, and that is activity. Sometimes that's hard for CCI patients, obviously, but if you're not a CCI patient, that can be something that you want to increase. Number 2 is nutrition, and that is eat a clean, healthy diet. Dr. Pitts on the Regenix site has a great book on eating a clean, healthy diet. You might also consider reducing your calories there. And then the third one is supplements, meaning anti-inflammatory supplements and other supplements that may help the procedure proceed more smoothly. And we've got a stem cell support formula for that we put together many, many years ago. So those are the big 3 things I look at. Sharon, can overstretched posterior ligaments or muscles cause a high translational BAI, or is it more an anterior problem? Overstretched posterior problems or posterior ligament problems could cause some increase in the BAI, but realize it's a couple different things, meaning the spine has columns. It's got an anterior column and a posterior column. In the anterior column, down lower, we have a disc, but in this area, we'd have a piece of duct tape or a ligament in the front and in the back of the anterior column. So AAOM and some of the superficial cervical ligaments between C1 and the skull. And then we've got the posterior column. And in the posterior column, in this case, we would have things like the PAOM, the nuchal ligament, supraspinous, interspinous ligament, etc. So if you're going to have a translational BAI, it's probably all of the above, meaning that if you just got one of those injured, you probably wouldn't have much translation. Rob Long, numbering those questions. That's great, Rob. Thank you. How many visits without results for curve correction or orthogonal adjustments would it be safe to say it's time for regenerative? Most chiros I know will keep you coming and coming. You know, Rob, that's a great question as well, because I think it brings up, we work with some fantastic chiropractors, and the ones we work with, kind of know when to stop. They know when they've done too much and they're not really getting the person any place. And they tend to be more clinicians than business people. They're really concerned about their patients. They form a close bond with their patients. And when they can't help their patients, they refer them out. Now, what you're talking about is the chiropractic profession, not that different than the medical profession, has folks that are much more business oriented than clinically oriented. And yes, you can certainly get in that situation where you as the patient have to be the one that says, I'm not going to do this anymore. So when do you know? Usually we're talking about after a couple months of that type of care, you're just not holding. So you might get some good results for a day or 2 or 3, but then things just all fall apart. And so I wouldn't go much deeper than that unless there's some really great reason you can be given showing that you're making good interval progress along the way to getting completely in place. But that's what I'd say. But again, we work with some great chiros that are more than happy to say, Uncle, what I'm doing isn't helping, go see this guy. Sharon, to build on my previous question about muscular instability, how do you determine if it's just muscular or if one has minor ligament damage? Yeah, it's a great question, Sharon. We can see on upper cervical MRI cuts, the most common thing that you would see would be atrophy of the stabilizing muscles in the high upper cervical spine. And that would include the suboccipital muscles here and also the segmental muscles around C2-3. So if someone, for instance, has very little abnormal motion on DMX or upright MRI, but has that atrophy, then you're in a situation just as you described, where you basically have muscular instability and you don't have ligamentous damage. Greg Beavers, for someone with moderate CCI 01, C1, C2, what are the chances that PRP from the posterior is sufficient or they need PICL? I'd have to know more, Greg, about what level of instability we're talking about. So for example, let me give you a concrete example here. So let's say someone has an overhang of 5 millimeters on lateral bending DMX open mouth view. In that case, again, there's about a 1 in 5 chance that posterior PRP will get it done, a 4 in 5 chance they'll need PICL, just as an example. Kristen, how long would you wait between PRP and PICL? When should I move on to PICL if I know I have transverse alar ligament damage? Yeah, it's a good question. As far as a posterior PRP is concerned, I wouldn't wait more than about 4 to 6 weeks. That's where we're seeing the sweet spot of that kind of treatment come in, meaning by that time, you're going to get about 80 to 90% of all the effects you're going to have from that treatment. And so obviously, if you're in that situation, you do a posterior and you're like, I'm 10% better after that time period, then it's probably time to move on. Conor, if when looking down, you feel the skull and C1 slide forwards, is this transverse laxity or transverse ligament laxity? I quite literally feel a clunk. Yeah, Conor, that's definitely a cause for concern. That would be transverse ligament. Also, the alar ligaments can also provide that stability, but transverse primarily. So if you're feeling a clunk when you look down, that definitely needs to be looked into with a DMX or one of the other types of movement-based imaging, just to make sure you're not getting an awful lot of motion there, because you don't want that DENS banging into the spinal cord. Sharon, sorry for asking so many questions. No worries. What determines if it makes more sense to do posterior PRP rather than PICL when you look at the scans? So as I was just saying, I think I gave a DMX example, and you're talking about a posterior hyperintensity on the MRI. So Sharon, we'd have to know, I mean, the biggest problem with static MRI and looking at the status of how the ligaments appear is that you don't really know if the ligaments are strong or not. And so in that case, what I would recommend is getting a movement-based image to try to see if the ligaments are doing what they're supposed to do. If they're not, then again, I think you're in a situation where it's a 1 in 5 chance that posterior PRP will get it done, a 4 in 5 chance that you'll need PICL. But just the posterior hyperintensity by itself would be hard to really qualify. Daniel, CXA of a difference from 148 in flexion to 178 in extension, is this the measurement for alar ligament damage? You know, Daniel, so let's just, so everyone understands, a CXA or claviaxial angle is the angle between the skull and the spine. Now, a CXA is only really reported in neutral, and we know what those ranges are supposed to be, about 135 to 155. What's less understood is what a CXA is supposed to be in extension, but 178, just from my looking at these things for many years, seems very high. And then it wouldn't usually be alar ligament damage. It would be the ligaments that go usually in the front of the atlas, between the skull, the atlas, and down to C2. Those anterior ligaments are what would allow that kind of crazy CXA to happen. So not so much alar, although they may also be injured, but specifically those ligaments in the very front of C1 and C2 and the skull. Submitted in advance by Sherry Scott. Off the scheduled topic, have you had any success treating hip ligament tears? I'm a figure skater, and I believe I may have torn something in there, as my X-ray doesn't show anything to explain the pain. Yes, we have. In particular, in figure skaters, a ligament to look at is a ligamentum teres. So ligamentum teres is the ligament that when you bring your leg all the way up, I can't do that. I haven't been able to do that in a long time. I couldn't even do it when I could do it. But I know figure skaters do that, and then they hang on that ligamentum teres. Now, it's not easy to get imaged. In fact, we've only found a few places on Earth that can image it well. But sometimes we can see it on a routine MRI, and sometimes, you know, we can just treat it based on a clinical diagnosis. But ligamentum teres is probably the one you want to be looking at. Era, I have muscle dysfunction in the neck and other places, and I think this has further caused CCI. It also seems to cause a dysfunction in the connective tissue, making it softer. Have you known PRP to go bad? I'm worried this dysfunction may affect how it heals. Could this dysfunction stop after PRP and possibly a PICL? I've been losing neck muscle mass and the muscle dysfunction causes a connective tissue worsening. Well, if you think you have a connective tissue disease, something like hypermobile EDS, you might consider doing a Beighton score online, BIEGHTON score. Just look that up on Google. There's a simple test you can take to see if you're hypermobile. If you think it's some other kind of tissue dysfunction, then we'd have to talk about that. But at the end of the day, hard to make a diagnosis given this information. Other than happy to take a look at all of your information and get online and do a one-on-one telemedicine eval. Era, I don't have mast cell issues as far as I know. Thank you. What if tectoral membrane is damaged? Yeah, so same thing. So the tectoral membrane is going to be the extension of the posterior longitudinal ligament all the way up. Tectoral membrane can be treated, although again, it's a little higher risk because of where it's located, but it can be treated through a PICL procedure up front. Pia, my son is hypermobile on the inside of one knee, or I think ligaments attached. He has some bone growth. Would that indicate instability in that joint or possible uneven alignment causing traction on the ligament, then causing bone growth? What treatment could help? Is it indeed instability? Yeah, if he's only hypermobile on one side, that means he's either off balance because of a scoliosis or some other left-right imbalance, or has injured that ligament, in which case the treatment for that could be anything from prolotherapy to PRP to bone marrow concentrate, but it usually can be treated. But it usually indicates instability more than anything else. Chris, will advanced orthogonal throw-up diagnostics like DMX are trying to get diagnosed for CCI should not throw off diagnostics like DMX. Paola, maybe, correct me if I butchered that, is atlas lateral shift 2.54 millimeters during left lateral bending, right lateral bending 0.47 millimeters severe DMX. Is this CCI what we should suggest? Regular injections, PICL is too severe for injections, need neuro. As I was saying before, a 2 millimeter overhang of C1, C2 is about a 2/3 chance for being traumatic CCI. Once you get to 3 millimeters, a 95% chance. 2 to 3 millimeters would be mild CCI, and obviously could be treated all day long with something like a PICL procedure. Now, just so people have a sense of it, when we get to kind of 5 millimeters, that's moderate. Once we're in the 6, 7, 8 millimeter range, that's severe. Also, bilateral jugular vein compression causing intracranial hypertension. Why is this happening, and what do you suggest? So, Bill, I think the biggest thing there is making sure that we have some imaging that's showing internal jugular vein compression, but the internal jugular vein goes right in front of the atlas, and when the atlas moves forward, usually on one side, it can compress that, causing some intracranial hypertension, because that's how the blood drains from the brain. And so that's usually caused by CCI, but we'd want to see that happening. Usually on a CT venogram is where it's caught. Era, my C1, C2 is most likely twisted. Imaging will have to confirm. Would that cause a problem for treatment? No, Era. The vast majority of our patients would have a rotational component at C1, C2. Stevie Ann Williams, in case of C2, 3, or C3, 4 instability, do you also inject muscles when doing the PRP procedure for these areas? yes, we can if we think there's muscle tendinopathy happening in those levels. Higher up for CCI, our focus would be on usually injecting the rectus capitis posterior minor muscle because that jacks directly into the dura. Conor, when the skull slides forwards and stops with a clunk, can the posterior ligaments be the culprit for this? What's very strange about my instability is that I do not have many neurologic issues, but a major bobblehead or feeling like my C1 is lifted up posteriorly and dropped anteriorly. Yeah, that's usually, again, as we were talking before, Conor, an indication of some laxity in the transverse ligament primarily, the alar ligament secondarily, and then the posterior ligaments kind of on a tertiary basis. Sharon, how do you determine when one can start doing PT and CBP after PRP or PICL is just a case of trial and error? More a case of trying to make sure the person's ready. So we actually have, well, when it comes to physical therapy and active physical therapy, we've got exercises online that the person can do. And those exercises can tell us pretty quickly whether or not you're ready, meaning you're going to crash and burn if you're not. And then when it comes to CBP, I always tell patients to roll up a towel, put it behind here, lie face up, experiment with different widths of the towel. And if that feels great, you're ready for CBP, i.e. it feels great and it doesn't flare you up. If that flares you up, then not ready for CBP. Okay, guys, I think we got through a bunch of questions. Any other questions that I can answer? I think this is a better format. Again, just experimenting with different kinds of formats to see if we can nail this whole Facebook Live thing. Sharon, is it possible to get a traction effect with PRP or PICL? No, not usually. I think what you're talking about is neurosurgical treatments where they go in and they try to raise the skull relative to the spine. And there you can get a spinal cord traction effect, and that could even require something like detethering. During a PICL, not quite sure how that would work, meaning that we're not really raising anything or providing any additional height to anything. So hard to see how that one would function. And then Conor, I don't have upright MRI, only basic 2T supine. Would this be accepted for a PICL procedure? Would it be looking for more imaging? Also, can you answer roughly how much one PICL costs? Sure, Conor, when it comes to upright MRI, if you have a basic cervical MRI, the best way to go would probably be just getting a DMX because that's the most likely to show CCI. Now, if it turns out that we can't see it on there, we can always get the upright, but that's the most likely thing. So that's what I'd probably recommend as a next step if you just have a basic cervical MRI image. PICL runs about $8,000 or so, but that also depends on how much we're doing versus just PICL ligaments, adding in facet joints, doing multiple areas of the body, et cetera, et cetera. Rob Long, both Conor and I were put on a rolled towel both Conor and I, if we put a rolled towel under our neck, our C1 or whatever slides out in relaxation, clunks and lifting our head. Yeah, so definitely then not a good candidate for CBP in that case. So that's a good example of when you just would say, not for me right now until I get more stable. Any other questions, guys, that I can answer at all? Okay, I think we'll start closing it out there. Chris just came in with a question. Do some people have just lower cervical instability? We'll be able to tell the difference. Main symptoms are neck and back of head pain, bobblehead, shoulder drop, and shoulder upper back pain. Tried running a few weeks ago and aggravated symptoms. Yeah, Chris, some people do just have lower cervical instability. DMX is a great way to tell the difference between the two. So that's probably the next step. And then Conor, yes, it feels like your head quite literally splits away from C2 over roll towel. Yeah, then Conor, great example of when you just skip over CVP until you get more stable for sure. You should totally see my DMX. I repeat the supine clunking. Sure, happy to look at it. Always interested to see those super interesting ones. Having issue, Jay Vick, I'm having issues with my shoulder, lower back, looking into hydro. How would you determine priority over what to treat when it comes to additional procedures with CCI treatments? So issues with the shoulder, lower back, we normally don't use much hydrodissection in those cases, if that's what you're talking about. So I'd have to know what it is we're treating there. And really the priority when it comes to adding those things into CCI really starts with what bothers you the most or what might be impacting the CCI the most. So take, for example, someone who has some lumbar spine scoliosis that's going all the way up to the head and we know is kind of pushing things off to one side. Then treating that lumbar spine scoliosis, if it's symptomatic, would probably rise to the top. Or someone who doesn't have that, but they've got neck and shoulder pain, and while their neck really bothers them quite a bit, the shoulder is a close second. That's a good example of treating neck and shoulder. Brittany, how large of a translation at the skull can PICL help? When it comes to lateral bending C1, C2s, quite a bit. We've treated, they max out at around 8 millimeters usually, and we've treated those cases successfully, showing marked decreased translation on repeat DMX. We've also, I think I recently just posted an increased ADI that went down from much more than a centimeter to about half after a single treatment. So quite a bit. And then Conor, when I breathe in, I have cracking and C6 to T1 constantly. You know what that is? It's not painful, but it happens all day long. Yeah, Conor, that's probably degenerative instability, which is not uncommon, but something that'd be good to take a look at on a movement-based film to see if there's movement-based instability that we can document down there. Rob Long, for your clunking interest, everyone. Oh, thanks, Rob. I'll take a look at that later. Brittany, I'm at 10 millimeters. Brittany, I need to know what 10 millimeters represents. Is that a Grab Oaks measurement? Is that an atlantodental interspace? A translational BAI or BDI? Is that C1, C2 overhang? So let me know. Magda, when a patient has both SI joint instability and upper cervical instability, how common is it that the SI joint treatment would pull the atlas out? I think a good way to think about that, Magda, is a sailboat mast, right? We all know perhaps that a sailboat mast is kept up by these very, very taut wires. And if I were to clip one of those wires at the bottom, then we would certainly see some deformation at the top. So in the case of SI joint instability, we usually try to treat the SI joint instability at the same time as the upper cervical instability because they can relate to each other using that model, and that's called the tensegrity model, meaning that the body is like those taut wires around a sailboat mast in that they have to be balanced for everything to be straight. Pia, I haven't been able to find an answer to this. After CCI, AAI, my son and I both have difficulty having our jaw, I think that's jaw, kept closed in the resting position. It's just too hard to keep it closed. Never been an issue before CCI. Yeah, so Pia, that's not uncommon. The whole jaw mechanism, and this is called the strap mechanism, can become a secondary stabilizer of the upper neck in CCI patients. So they tend to get overloaded issues in the jaw because they're basically trying to use the jaw muscles to hold their head on. And so we frequently see a crossover in CCI patients between upper cervical issues and jaw issues. Daniel, what does thickening of the left limb of the transverse band of the cruciform ligament mean? Yeah, so generally thickening on an MRI means that portion of the ligament has tried to heal itself, but is probably weak, meaning thicker ligaments are weaker and thinner, denser ligaments are stronger. So it probably means some weakness in that left transverse ligament. Transverse band of the cruciform ligament is just another way of saying the transverse ligament. Stevie, is BII translational distance of 6 millimeters treatable by PICL? Likely, Stevie, I'd have to see your imaging to be sure, but likely. Sharon, are you able to do a session about the function of all cervical ligaments and muscles and the movement they are responsible for? Sure, I can do that. Probably better to write that as a blog and then maybe do a session on it. And we actually, if you look at that, that's in the book as well. So for those of you that don't know, I've got a book on CCI. And if you go to the Regenerative site or the Centeno-Schultz site, you can get that book and download that book. And that book goes over all the function of all the ligaments. So Sharon, that'd be a good place to start. And then Stevie and Williams, how would one know if they had SI joint instability? Normally there's pain in the SI joint. Sometimes there's popping and clunking in the SI joint. Other times it's a clinical diagnosis based on hands-on exam. So you, at the very least, would have to be examined by someone who knows how to look for SI joint instability. That would be the vast minority of physicians, but we look for it all the time. Osteopaths in that case would be better than MDs at diagnosing that, and manual physical therapists, and again, that's a small portion of physical therapists, would also be very good at diagnosing it, including chiropractors. Brittany, sorry, I think it's BAI 10 millimeters translation forward and back. Yeah, so Brittany, let me look at that and we can discuss it together and try to see what's going on there. Conor, I have HEDS with instability in my entire T-spine, rib attachments, lumbar spine, shoulder, knees, etc. I'm currently getting prolotherapy at my entire spine, C2 down, while having an unstable skull make this harder to tighten the vertebra down. Currently, PICL is not affordable, so I'm trying to fix other issues. Certainly, Conor, I think it's a good idea to get everything you can treated with prolotherapy and then see what's left. Janelle, if DMX shows return to normal in cervical spine after PICL or a PRP treatment, can a patient ever return to normal sports activities, water skiing, or similar? Janelle, it's certainly possible. One of my patients, for example, returned to jiu-jitsu fighting. And I think that was after, I think we probably treated her twice. So it's definitely possible. A lot of that depends on how disabled the person is. And I'd still probably stay away from high impact, more violent things like water skiing. But for example, bike riding, running, those sorts of things. But my concern with water skiing is that even good water skiers, as you know, sometimes really get a lot of force placed on their head from falling in the water while going fast. Conor, at Steve, static type pains, cracking, clunking, sharp pain, not quite sure what that means. Chris, can local genetics perform posterior PRP of neck with contrast? Yes, but really not in the high upper cervical spine at 0-1 and 1-2. So that would only be if there was an issue from kind of C2 down, but not if there's an issue from C2 up. So let's say C2, 3 down. So they wouldn't be able to deal with 0-1 and 1-2. Sharon, does early hip degeneration mean SI joint instability per se? No, sometimes the two are not related at all. Sometimes they're completely separate. Sharon, can you give some examples of examinations you perform the C-spine prior to injections as a part to determine what's going on? Sure, Sharon, we do a complete palpation exam of every single facet joint from 0-1 all the way down to 7 or C7T1. We also look at things like range of motion. We look for various tightness in specific muscles, including that rectus, capitis, posterior, minor. We look at nerve sensitivity at greater occipital nerve, lesser occipital nerve, third occipital nerve, the superficial cervical plexus, and other areas. Look at TMJ function, look at other types of specific physical exam tests like joint position error, etc. So kind of a very long list of things. Yeah, so Carol is talking about the book, and I'd really encourage you guys to download and read it because I think it's an excellent way to learn about this topic. Brittany, my last question. I'm in postural PT right now. My PT doesn't want me to put my ears over my shoulder because of my translation, but I'm trying to fix my posture. Would that be something I would want to do, or is it really that bad for someone with large BIA to have it stand up straight? You know, Brittany, I've got to look at your imaging to see. I mean, trying to correct your posture is almost never a problem. So I can't imagine why that would be an issue. But I'd have to see your imaging. I think I've already answered that one on Sharon. Could SI joint instability cause CCI, AAI? Much less likely that SI joint instability would cause CCI or AAI. And also, obviously, another link for the CCI book. So that'll be down in the comments there. I really hope that the PICL could come to the UK, Great Britain. Yeah, Conor, not anytime soon. A lot of work to do on PICL before that happens. So it's probably going to be many years before that occurs. How common are one and done CCI cases with PICL? Yeah, Conor, I tell patients about 1 in 5 patients that gets a PICL is a one and done. So that gives you hopefully some sense of that. Sharon, can you still have normal range of motion with AAI? Sure. Yeah, especially if you're hypermobile, right? A lot of hypermobile people have AAI, but they've got great neck range of motion. Paola, hi, so sorry again. Thank you for answering. I've already had CTVs and catheter venograms and particular vein stents placed at C1 level, which are both crushed by C1 lateral mass. Yeah, so again, if it's getting crushed by the C1 lateral mass, that's instability. So obviously the focus is to get the instability fixed there. Okay, I think I'll take 3 more questions. If someone came up with 3 more questions, because we're coming up on the hour here, and I've got a meeting at 2 p.m. my time. Magda Moss, do you always treat the whole pelvic ring if only one SI joint has been injured? Not always, but usually. And the reason is that it is a pelvic ring, so it's got a joint in the front and 2 in the back, and so we try to treat it as a whole unit. And then Sharon, does CCI get worse over time in all cases if you don't get treated? Usually, yes. I mean, my biggest concern is that it can move into a category where it gets more difficult to treat because the neurologic injury becomes more permanent. So that's my biggest concern for all CCI patients is that there's a difference between seeing a patient that's been out there 15 years and who just got this 5 months ago. So that would be a concern. Okay, guys. Well, thank you so much. I hope you like this new format. Still messing with all of this. Hopefully this worked better this time. And I will be on the Regenix channel this coming Friday, so I look forward to seeing you there. And we'll again do the same thing. We'll talk about a specific topic, and then sky's the limit on questions after that. So thanks so much for watching, everyone, and have a fantastic week.